A pleasure to introduce three distinguished speakers today. This is the session about reproductive medicine. The first speaker is Dr. Muhammad Bashir. He comes to us from Doha. He's the head of the National Diabetes Center at Women's Hospital. He's a consultant endocrinologist, and he will tell us about the management of hyperglycemia in pregnancy. Please help me to welcome Dr. Muhammad.
So thank you very much, Dr. Ryan, for the nice introduction, and thanks to the organizing committee for the invitation. So that's the way we're going to progress. Great. So I have no conflict of interest. So diabetes in pregnancy, as we all know, has a negative impact on the mother and the offsprings. And both are at high risk of developing complications during pregnancy. So the mothers which have long-term sequelae as well. For example, PET, pregnancy-induced toxemia, severe complication during pregnancy, have a high risk of mortality, but on a long-term basis has a high risk of cardiovascular disease. Similarly, in the fetus, macrosomia, large for date, all of these complications can impact the outcomes during pregnancy, but have long-term sequelae as well. More critical of that mothers with gestational diabetes, offspring born to mothers with all forms of diabetes are at high risk of developing type 2 diabetes and all the spectrum of the metabolic syndrome that you are aware of. And it's the intrauterine environment that seems to impact the fetus most. And it's not only glycemia, it's also obesity, overnutrition, and hyperglycemia. And all these factors impact the fetus in different shapes and forms. Number one, they impact the fetal size. And we know that a large for gestational age baby is more likely to continue to be obese throughout childhood and are more likely to end up with early onset type 2 diabetes. Similarly, small for gestational age end up to catch up and at high risk of diabetes as well. This intrauterine environment seems to impact the epigenetics buildup, makes them more susceptible to type 2 diabetes in the future. More critically now, we get to know that the intrauterine environment impacts the ability of those offsprings to store fat in the adipose tissue. So they're more likely to spill those fats in the internal organs. And it's not a surprise that we found that when you assess them as early on, you'll find early evidence of beta cell dysfunction and early evidence of insulin resistance in those offsprings, and that's in all forms of diabetes. And the intrauterine environment is another factor that seems to regulate the appetite, and they are at higher risk of having lower regulation of appetite. They have more hunger feelings. And the new kid in the block are the microbiota. Already the mothers have an underdeveloped, disadvantaged microbiota buildup. They inherit those from the mothers, and the high rate of cesarean section doesn't help those children either. So there are multiple things that are happening during pregnancy that impact those children on the long term. It's not all about the pregnancy outcomes, it's the long-term sequelae that we should worry about as well. And there are three different forms of diabetes in pregnancy. They all come under the same category. But gestational diabetes is the most common that you see in your clinics. Currently, the second most common one we're seeing are type 2 diabetes, and there's type 1 diabetes. They're all called diabetes in pregnancy, but there are three different diseases, completely different diseases, and they require different approaches. And one of the main factors that makes them different is that the relationship between the mother and the offspring that I just told you about is accumulated through the placenta. And there are multiple factors that we now know impact the placental development. The hyperglycemia, lipids, which is the new thing that we need to pay attention to, and the duration of exposure to both these risk factors over a period of time. That modulates this relationship quite significantly. So to go back to the same slide, type 1 diabetes in particular is a complete, distinct, different disease from the rest. So for the rest of the talk, I'm not going to talk about type 1 diabetes. It requires a different approach. Most of the talk is going to focus on gestational diabetes. I'm going to touch base for type 2 diabetes for the sake of time. So how common is GDM? So the most recent IDF data basically told us that globally it's 14%, and in our region, the MENA region, is 30%. So we have looked at 99,000 deliveries in our cohort. 83% of them have been screened, and the prevalence of GDM is 31% in Qatar, not far from what the IDF suggested. I'm not going to talk about the screening for GDM because this is a difficult topic with a lot of controversies. So let's focus on how we approach those patients. And quite critically to understand, when we're looking at those patients, that are multiple factors that impact the outcomes. The pre-pregnancy BMI, how much the mother gained in terms of weight, and what's the glucose levels. And if I want to put them in kind of in hierarchy, I will go exactly the same. The pre-pregnancy BMI, how much weight she gained, and then the blood glucose. I'm going to tell you each one of them how it impacts pregnancy. So maternal obesity is the single risk factor that increases the risk of gestational diabetes. And it's actually increased the risk of all adverse pregnancy outcomes in a dose-dependent fashion. The higher the BMI, higher the rates of complications. And the recent meta-analysis suggested that 24% of all pregnancy complications could be explained by prematernal obesity per se. And if you want to dig deep or zoom into that, you will find that, well, the rates of macrosomia, large for gestational age, are increased, preterm deliveries, cesarean sections, PET, and even congenital malformations. And if you go through all of these, you will find that all of these are increased in a dose-dependent fashion. The higher the BMI, the higher are these complications, regardless of the presence or absence of diabetes. And the HAPO trial, which was an observational trial, patients were screened only, not treated, went back after to look at the criteria of GDM and looked at their cohort of patients and divided them into patients with GDM and no GDM, and obesity and no obesity. And they looked at 3 complications: large for date, cesarean section, and preeclampsia. And the reference here is women with neither, no GDM, no obesity. So in women who have obesity but no GDM, you can see that the odds ratio of these complications are increased significantly, especially the preeclampsia. If you want to look at GDM patients with no obesity, you can see that difference is not that much. In anything, some risk factors are less seen or less likely to happen in GDM alone. But when you combine the both together, you'll find that the complications start to increase quite significantly. Now, the next important part is how much the mother gains, and just excessive gestational weight gain, and underappreciated risk factors by both healthcare professionals and the women themselves. And it adversely impacts all forms of diabetes in pregnancy. Type 1, type 2, gestational, all forms are impacted by excessive gestational weight gain. I told you gestational obesity is the highest risk for type 2 for gestational diabetes, and excessive gestational weight gain is the second critical risk factor for increasing the risk of gestational diabetes, especially if it occurred before 20 weeks, to be modest, before 15 weeks, to be specific. So the higher weight gain early on, the higher the risk of complications. And meta-analysis of large networks showed basically that excessive gestational weight gain increases the risk of all forms of complications. Hypertensive disorders that I just told you carry very serious pregnancy complications and long-term sequelae, and large for gestational age and preterm labor. So how try and put all these risk factors together? Obesity, gestational diabetes, and excessive gestational weight gain. And this paper that looked at a very large number of deliveries tried to answer the questions. I turned them into blocks like that in order to explain it easier rather than the table. So at the bottom here, you will find the different forms of classes of weight. And then in the blue lines, blue bars, you'll find the risk of large for date in those women who have no diabetes and have adequate gestational weight gain. And as you can see, the rate of large for date is increased in a dose-dependent fashion. 2 risk factors are not there, no diabetes, no excessive gestational weight gain, but we're only talking here about maternal obesity. And now the second red bar are patients who have no diabetes but have excessive gestational weight gain. And you can immediately see that the rate of large for gestational age started immediately to increase across the whole groups, again in a dose-dependent fashion. Women in the green bar had gestational diabetes but did not gain a lot of weight. And you can appreciate that in the majority of the weight brackets, that it carries a little bit similar or at sometimes lower risks of large for gestational age compared to the women who had excessive gestational weight gain. And now, putting them all together, you find that the risk increases quite exponentially in those patients. So if you want to take any message from this, that gestational diabetes, excessive gestational weight gain carries exactly the same risk factors of gestational diabetes, exactly the same, if not more, at any point in time. So can we stop just excessive gestational weight gain? Can you do anything about it? And you can. So one of the studies that tried to put the brake on excessive gestational weight gain is a study that came from It came from Denmark, where they used a very low-calorie diet, 1,400 kilocalories diet, regardless of what the woman gained beforehand, but that after the diagnosis of GDM. And what they found is they managed to have glucose benefit, lower HbA1c, lower rates of insulin, and lower rates of large for gestational age. A small study, wasn't particularly very well powered. But there was no difference in adverse outcomes. So there was no high rate for small for gestational age, no ketonuria. We replicated this, and hopefully we'll be able to report it to you, but we didn't use 1,400, we used 1,600 calories, because this is the lowest recommended amount of calories for safe pregnancy. Hopefully we'll be able to report it to you, but we have positive results. But the question is, what is an adequate gestational weight gain? And everybody kind of aware of the Institute of Medicine guidelines, and which is, in my point of view, and everybody, and a lot of people's point of view, is quite excessive. So if you're looking at obesity, all classes, they can gain up to 9 kilograms of weight. That's quite excessive. A most recent large study that linked weight gain across different weight categories and looked at complications, called the Life Cycle Project, found that, well, we were correct. You need less weight gain in obese patients. And they come up with different recommendations. And I think it's a matter of time before we see this reflected in the guidelines. But I can warn you that these patients were all Caucasians, who seems to be well blessed by their ability to store fat in the subcutaneous tissue compared to all other races. So it might not reflect to us. So we have, in Qatar, in our guidelines, we have taken some drastic measures. We're looking at gestation weight gain on a weekly basis. We're looking at before or after 20 weeks, and we're trying to get pretty much 1/3 of the gestation weight gain in the first 20 weeks and the 2/3 at the end. And for obesity classes, we're looking for no gestational weight gain in the first 20 weeks and then restricted weight gain thereafter. Now, obviously, after what I said, diet is the cornerstone of the management of those patients. And the diet which has more evidence is the low glycemic index diet. And that's what we based our diet plans on. But success of diet can only be measured by your ability to control the gestational weight gain. So if you decide on your success by looking at the woman's glucose numbers and you find that the numbers are fine, but she's gaining a lot of weight, as I just told you, it doesn't matter. So the risk of complications are exactly the same. So you should be able to stop the excessive gestational weight gain. If it's not working, you have to try and get her to meet the dietitian more and more. And as I said, we use 1,600 calories in those with excessive gestational weight gain where we need to apply a brake to them. And that's the lowest we got, and we have good success with stopping this in 2/3 of the patients. Exercise is critical. We're not asking them to run on a treadmill. We're asking for simple exercise of walking for 30 minutes. There is good evidence, not in pregnancy though, but outside pregnancy, that walking for 10 to 15 minutes after each meal reduces the postprandial glucose excursion. That seems to work better with our women, and it seems to be more compliant with doing that, and we have better results with the postprandial excursion when we do it, as long as they're compliant with it. So what are the glucose targets we should aim for? It's the ADA targets of a fasting of 5.3 millimoles per liter and a 1 hour of 7.8 or 2 hours of 6.7. You can pick and choose which one you want to work on, 1 hour or 2 hours. Very equivalent. People can argue and can make a case for either of them, but you just whatever you're used to. However, I want to stress that these are expert opinion, and if there's any evidence for these targets, they're coming from GDM patients in the 3rd trimester. So you can tighten up the control, you can loosen the control according to how the patient, how the baby is responding. Nowadays, we have the CGM. We offer the CGM for our women with insulin-treated type 2 diabetes or gestational diabetes. All our type 1s are offered the CGMs. The consensus guidelines told us that you need to aim for 70% of the readings in type 1 diabetes, but they did not tell us how much you need to aim for in type 2 diabetes. And just leaving things loose is not a good idea. You need to have an anchor to work on. So in our guidelines, we decided to anchor it around 80%. So we aim for 80% of the readings within the target of 63 to 140. Try to aim higher as long as you're not causing any hypoglycemia. So that's the way we use, but we only offer GDM and type 2 diabetes women on insulin, the CGM. So applying the dietary measures, the exercise, success rate varies across literature. In our own cohorts, looking at about 800 women, about 16% of them need to progress to take any form of pharmacotherapy. And our first line of treatment is metformin, oral metformin, which has been in use for a long period of time. And there are multiple meta-analyses that shows its efficacy, comparing it to insulin, comparing it to sulfonylureas. It has a lower risk of macrosomia, large for gestational age. And a most recent meta-analysis that we collaborated with Qatar University that basically showed it has maternal benefits as well. So less maternal hypoglycemia, less gestational weight gain, less large for gestational age. Doesn't seem to have any effect on PET or PIH or hypertensive disorders. Now, the worry about metformin, or people argue about metformin for many reasons, and but one of them is that women will eventually require to go on insulin. And yes, that's true. About 35% of the women in our cohort requires insulin supplementation, but other populations reported different rates. There are people reported 56%, 60% will require supplemental insulin. So metformin is gaining more and more widely accepted in terms of treating during pregnancy. The NICE guidelines clearly recommend it as the first line of therapy, and then you move to insulin if the patient cannot tolerate it or does not accept it. Now, there are multiple guidelines from multiple societies that endorse metformin as one of the options of treatment. You can offer it. The Americans still on the edge, and they say if insulin is declined, use metformin. But most of the other guidelines will say, talk to the patient. If she accept metformin, go ahead with metformin. But the NICE guidelines are the only one that put metformin as the first line therapy. And that's what we do. We offer metformin as a first line in our treatment. When do you stop metformin? Well, the worry about metformin is in cases where there is placental insufficiency, that it might increase the risk of cause fetal acidosis and can exacerbate small for gestational age. All this evidence comes from animal models, didn't come from human models. However, the worry about metformin in the transport of other micronutrients as well, so it could have the potential of worsening the delivery of fatty acids and proteins, and can exacerbate conditions where there is a high risk of small for gestational age. Definitely when there is an IUGR, definitely when there is a preeclampsia, we'll stop it. And then women who have at high risk of a small for gestational age, hypertension, nephropathy, and bariatric surgery are the main ones that we see in our clinics. And if they have one of these, I'd be very cautious using metformin. If they have two or more, I probably would not use metformin because of the risk of small for gestational age. Now, ultrasound monitoring is very, very critical. It has better to be started as early as 24 weeks gestation. Abdominal circumference of the baby is the best available marker to monitor from our point of view. Usually, we aim to keep it between 10 and 90th percentile. Some units will use 5th to 95th percentile, but we use the 10 to 90th percentile. And when you plot it, you can see that babies can behave in different ways. Babies could be started small, will continue to be small. Some people are large, continue to be large. And some of them will continue across in a steady growth. That shouldn't worry you. What worries you is this picture. Baby crossing the line where you need to tighten the control, or baby size going down when you might need to loosen the control a little bit. And this is very, very critical to take into account, especially after 34 weeks gestation, to decide where to go. Now, for the sake of time, I'm going to touch base about type 2 diabetes. So how common is it in pregnancy? So it depends on your unit. You probably look at the numbers, but the IDF told us it's not that common. So it's about 0.2% of patients around the globe. But in our region, I think it's about 2.4% in the MENA region. However, as I said, we looked at a large number of our patients. It's higher than that in our region. So about 2.9% have it before pregnancy, known it, and 2.2% we detected them early in pregnancy. So we're talking about the 5.1% of our population have diabetes, more type 2. It's more common among the Qatari population, it's approaching 6.6%. So it's not uncommon. And the outcomes of type 2 diabetes are much poorer than what you see in gestational diabetes, regardless of which cohort you're looking at. And this is just one of our experience. That was about 400 patients. And even if you try to correct for all the risk factors that I just mentioned, obesity, age, excessive gestational weight gain, the complication rates are much higher than what you see with the general population and what you see with type 2 diabetes. And the reasons that with the risk factors that we found that dictates these are actually the pre-pregnancy glycemia, how much you manage to get the HbA1c down by the end of the pregnancy. So the pre-pregnancy and the end of pregnancy glucose control, the pre-pregnancy BMI, and how much gestational weight they gained. And if you can see, you have two factors already being predetermined when you started the pregnancy, and then it depends on when do you get the patient before you try and impact the third trimester HbA1c. The earlier, the better. And we found a kind of a rolling ball rolling in our cohort. So we found that patients who started their HbA1c pregnancy with a HbA1c of 9% or above, we treat them intensively with insulin. They gain too much weight. By the third trimester, we find huge difficulty getting their blood glucose back to normal. And we find that in this group particularly, very few of them were able to achieve the target HbA1c, which is about 6.5% by the end of the pregnancy. And those are the patients end up with adverse outcomes. So because of that, again, gestational weight gain comes into play here. So managing women with type 2 diabetes, it's very, very critical to be aware of manage gestational weight gain. And you try to prevent it. Now, in our cohort, we offer the 1,600 calories, which is the lowest one, in all the women with a HbA1c conception 9%, because that's what our data showed us, and all the women with a BMI up 35 and above, in order to prevent excessive gestational weight gain. As I said, we were happy with the results so far, but when we're ready to present it, we will present it hopefully in this conference next year. So does metformin work in women with type 2 diabetes? The MITI trial was a randomized control trial that looked at insulin plus metformin versus insulin plus placebo. And their outcomes were all kind of hard outcomes related to the fetus outcomes. As you can see, none of them are glucose related, and they found no difference in primary outcomes. But you can look at the secondary outcomes, and you can think of why do I use metformin in type 2 diabetes? I use it in order to avoid excessive gestational weight gain. I use it in order to get more patients to achieve targets. I use it in order to reduce the amount of insulin, whether a long-acting or short-acting, and avoid hypoglycemia. So there are multiple things that you need to take into account, and all these secondary outcomes were positive in the use of metformin, but not the primary outcome, unfortunately, and that makes these findings not conclusive, unfortunately. When should you avoid metformin in type 2 diabetes? Hypertension and nephropathy, and exactly the same thing I told you early on about gestational diabetes. Anytime you think there is a high risk of small for gestational age, more than 2 risk factors, just avoid it, don't use it. Now, which insulin to use in those patients? Detamir is licensed to use in pregnancy, but there is data that looked at detamir and glargine from observational data, and they have a similar safety and efficacy. However, glargine or glargine U300 are not licensed. There is studies that looked at degludec, and detamir and degludec is now licensed to use in pregnancy. But let me tell you that insulin does not cross the placenta, and hyperglycemia is harmful. So really, really what I do is whatever floats your boat and gets you to the target, use it in the patients. Glargine, degludec, anything that gets you to go to target, you can use it in order to get patients to the target. Bolus insulin, the 2 licensed one are Lespro and Humalog, and Fast Aspart is also, Lespro and Aspart and Fast Aspart are licensed in the use in pregnancy. Now, the last slide here, I'm just going to talk about 2 things. One is the use of aspirin in type 2 diabetes. This is very critical as early as 13 weeks, or actually it's recommended at 13 weeks gestation, and that lowers the risk of preeclampsia. And we've finished analyzing our about 1,200 women, and now preeclampsia rates in our cohort was reduced by 60% after the introduction of aspirin to the management system. Now, the last part here is when do you deliver the baby and when do you start worrying about high rates of IUFD, because IUFD is something that always on the head of your obstetrics, and he's always on your neck about it. So this is a large series that basically looked at to see what are the risk factors for IUFD, and when does it happen? And what they showed is that the risk factors are extreme HbA1c, high HbA1c and extreme body weights. Very large babies, very small babies with high uncontrolled diabetes. And most of the death rate happened after 37 weeks gestation. So what we do in our clinic in timing of delivery is that we look at the risk factors at 35 weeks gestation, and then if no risk factors, we can deliver at 37 weeks. If there are any one risk factor of the two, HbA1c high, baby is small or large, we can deliver at 37 weeks. But if there's a combination of the two, sometimes we might go with the 36 weeks gestation and early delivery just to avoid undue or IUFD. And this is my last slide, and I'm just on time. Thank you.
Thank you so much for the outstanding talk, and thank you for being on time, exactly on time, Dr. Mohammed. I would like to call upon my co-chair, Dr. Ali Al-Maghbali. He will introduce my big brother.
So that was about hyperglycemia in pregnancy. Now, the second topic will be management of hypothyroidism in pregnancy. It is as equally maybe important also. And our speaker is well known to you, Dr. Ali Khalil. He is consultant endocrinologist at Reem Hospital in Abu Dhabi. And he contributed much to this association and the former East chapter. So the floor is yours.
Thank you very much. And it's a great pleasure to be here. I would like to thank the organizing committee for asking me to talk about this pregnancy and hypothyroidism. I could tell you, for those who really would like to know how I will go through that presentation, you will get all what you need to do about my topic in the first few slides. And at the end, you will have few slides about treatment, and then in between, it's up to you to watch your phone or do whatever you want to do. So first of all, I have no conflict of interest. And during that talk, my objective will be to highlight the changes that you see, physiologic changes you see during pregnancy, and to highlight on that basis, what are the changes suggested in TSH and 3T4, which were published initially by ATA in 2011, and again updated in 2017. And how it applies to 2023 at the present time, and to overview with you the confusing literature about the consequences of untreated subclinical hypothyroidism. We know in hypothyroidism, overt hypothyroidism, it's quite clear there are consequences, there are pregnancy-related adverse events that happen, and this is well established. But in subclinical hypothyroidism, it's really question left in the air, and then where really data is very much confusing based on few elements I'll mention about it. Finally, I'll highlight the key element decision in the treatment of hypothyroidism during pregnancy. Now, there are changes during pregnancy that are taking place, which have some implication why TSH and 3T4 do change also during pregnancy. The first one is that due to the increased estrogen production, there is an increase in the thyroid binding globulin, which really the globulin to which thyroid hormone bind. And the increase in TBG, which the consequence of this is that you're going to have increase in the bound thyroid hormone. And the second one, you're going to have to see a rise in the beta-HCG secreted by the placenta. Because of cross-reactivity between TSH and beta-HCG, TSH will be suppressed, but the stimulation of the thyroid will be there present. And there consequences, along with that, you will have increase in requirement during pregnancy. One, in iodine requirement for the formation of thyroid hormone. The second one is increased renal excretion of iodine, so there's a loss of iodine, so you need to compensate for that. And then there is transplacental transfer of iodine, and then the thyroid hormone are acted upon by deiodinases, which also decrease the amount of T4 that could cause the placenta. The end point is that you have increased total T4 and T3 production, which is estimated to be around 1.5-fold increase in what you see in the non-pregnant condition. So this is really what is observed. So the two things that you see clearly, one because of the increase in TBG and the stimulation by beta-HCG, that you will have decrease in TSH. And the other one is the increase in total production of free total T4 and total T3. The free T4 and free T3, they remain within almost the same range. So there is a compensation between what's bound and what remains free to act upon the cells. This is essentially what we see. The first element is that you will have an increase in green of beta-HCG. As a consequence of this, in the first trimester, TSH is expected to drop. So the value of TSH in pregnancy are lower than what you see in the non-pregnant condition. The second point, you will have increase in the total T4 and T3, as I mentioned, but free T3 and T4 remain within almost the same level, even lower than what you see in the non-pregnant condition. Now, if you look in the dashed line, if it happens that you measure for thyroid antibodies, that's something really quite relevant. When thyroid antibodies during early pregnancy are elevated, but along pregnancy, there is expected 60% drop in the level of thyroid antibody, and this is due to the immune tolerance that really occurred during pregnancy. But the relevant point is those who start with high thyroid antibodies are expected to have even higher level after delivery, and that's why we see a rise in the incidence of postpartum thyroiditis seen in patients presenting with antibodies prior to get pregnant. Having said this, this has a certain relevance too, is that those who have thyroid antibodies seem to impose on the thyroid some kind of a burden, so the thyroid doesn't really react the same way as it should normally. So in this case, your TSH, as you have seen in the normal pregnancy, when there is a drop in blue in the line, in those who have thyroid antibodies in red, you see the TSH does not follow the same pattern as seen in the women who have negative thyroid antibodies. Having said this, the fetus, it's well known that the fetal thyroid begins to make TSH at about 10 to 12 weeks, but it becomes fully functional at around 18 to 20 weeks. So during that initial period, the first 18 to 20 weeks, the fetus is quite dependent on the maternal thyroid hormone, which we know that is so essential for brain development and the formation of synapses within the brain tissue. So it's relevant to know that maternal TSH does not cause the placenta, but thyroid hormone and thyroid antibodies, specifically thyroid receptor antibodies, they do, along with thyroid antibodies for antimicrosomal antithyroid globulin. Having said this, since I mentioned there is a change in TSH, it's lower than we see in non-pregnant level, what is the normal TSH that has been adopted by the guidelines? In 2011, the ATA suggested that the use of first-timer TSH should be, the upper limit should be 2.5. Okay, and this was based on the initial studies done by Negro and his group. The initial one, he had it in 2006, where he looked at the impact of thyroid antibodies on the patient treated with T4 and untreated with T4, and on adverse pregnancy outcome like miscarriages and premature deliveries. And again, he looked at the impact of having TSH between 2.5 and 5, just to go along with what I mentioned about the upper level of TSH. And so he carried on the study in first trimester, having TSH between 2.5 and 5, negative antibodies. He evaluated close to 4,000 thyroid peroxidase antibody negative women TSH. And then the result is that he concluded that effectively the increased incidence of pregnancy in pregnant women TSH between level of 2.5 and 5 provides strong physiological evidence that the TSH should be redefined to be 2.5. And that's what impacted on the ATA guidelines, and other studies confirmed during that period that really that could be a case, and that's what happened. TSH was, upper limit was 2.15. With time and further studies were done, there were a lot of studies that objected on this, that because TSH is subject to a lot of ethnic changes. It's different between one race to another race, one ethnic background, another background, and depending on the iodine content within one region, another region. So different study came to confirm this point, that the ATA was influenced by the changes and the studies done, and they come up with the recommendation that the use of population and trimester-specific TSH and 3T4 reference intervals should be the gold standard, calculated in a population with no thyroid disease, optimal iodine status, and negative thyroid peroxidase antibodies. So, your TSH upper limit should be based on your own population, and it has to be trimester specific. Now, it's important to realize that as much this is really a good recommendation, but how many have their own population and trimester-specific values and done? We have done a study, actually, a few years back, and we published it. And we have some data related to Abu Dhabi, and only Abu Dhabi, not the whole UAE. And I have to say, really, that despite that study, it has not been adopted, and people still using what they know from their own labs. Having said this, how many do you think have been using the ATA guidelines? In your mind, 10%, 20%, 30%, any numbers? Huh? I'll tell you. This is based on this study. Actually, it was published recently. And they looked at 20 cohorts involving 63,000 participants were included in this meta-analysis. And 42 out of 102 studies in this systemic review could be used in a clinical setting, so they can make some clinical meaning out of it. And underlying in blue is actually our study is including in those 42 studies. Only 11% have been following the guidelines, because really nobody has data relevant really they could use. So some suggestions were made to you that the one way you could deal with that is, since TSH, 3T4 are the main hormones to be measured during pregnancy, that we could do is that if you could use the normal reference values for TSH in the first trimester and use in the non-pregnant. But you take the upper limit of TSH, which normally is around 4.5, and you decrease it by 0.5. And you do the same for the lower limit in the non-pregnant, and you decrease it by almost 0.5. So the upper limit will be like, if you want to use it, could be TSH, anything above 4 is abnormal, considered really the upper limit that you could use for TSH. Having said this, if you found that TSH is done, antibodies, you ask for antibodies, antibodies are negative, and your TSH in that range between 4 and 5, please do not act on it immediately. Repeat your TSH in 2 weeks' time or 4 weeks' time. 30%, in one study, 30% TSH repeated, TSH turned back to be within the normal range. So that will avoid you really going into a whole long list of things that you need to do during pregnancy. And if there is a discrepancy that you see between TSH and your free T4, because T4 has some limitation during pregnancy, the test has to be for Roche, it has to be, or different manufacturers, it has to be specific to pregnancy, and they have to give you those data related to that period. There's also discrepancy between different lab that you use. And if you have to, the T4, total T4 would be the test to use rather than free T4. And the way that you go with this is like, you know that there is increase in total T4 production, like 1.5-fold increase. by starting 7 weeks, by 15 weeks, you should expect that the total upper limit of TSA, total T4, is around 1.5, the upper limit for the non-pregnant reference range. And that will be your guide. So if you start by 7 weeks, you can add 5% onto the upper limit of TSH every week until you get to the 16 weeks, and from there you take the non-pregnant reference levels. And finally, if you thyroid antibodies, it's really recommended by the ATA if TSH is more than 2.5, and this is because it might have some therapeutic implication. I'll come back to that point. Now, what if you don't want to use any of those? Do you have any other options? What if you're I'm working in Abu Dhabi and Saudi have some reference range? The suggestion from this Ozenga, based on those cohort study that they did, a systematic study they did, you could use some, maybe the same as used in osteoporosis. You could use the data from a country that similar in population to your own country and adopt those one as a reference for you. This is the final recommendation by the ATA, and this is as far as really testing for hormones during pregnancy, knowing that for free T4, as you know, the gold standard is free dialysis, but very expensive, so you have to resort to really what I told you as means really to get the norm for that pregnancy. And this is here, you see the different cohort studies. Now, how do we define hypothyroidism, a normal status, and different stages of thyroid dysfunction? Euthyroid is when you have normal TSH for the upper range for your pregnancy, and with normal free T4. Subclinical hypothyroidism, TSH is high, but free T4 is normal. And isolated hypothyroxanemia, when your TSH is normal, but your free T4 is low. And overt hypothyroidism, when high TSH is high and free T4 is low. How prevalent is the condition in subclinical hypothyroidism? I have to say, really, I found few studies done in the Gulf to give a true prevalence of the condition. Maybe that should be a future research study that people should look into it. In US, where it's known as iodine deficient, the prevalence of subclinical is between 2 to 2.5%. For hypothyroidism, overt hypothyroidism is less, between 0.3 and to 1.5%. Now, symptoms-wise, not too much different between non-pregnant and pregnant, except for the heat that pregnant women that express. And the causes are in the western regions, chronic thyroiditis is number one. In iodine deficient area iodine deficiency is the most dominant cause. UAE is considered in our region now to be iodine sufficient, and based on the WHO study done in 2011. So we have considered that really, and it's coming really more prominent that you see chronic autoimmune thyroiditis, we see more frequently now in our clinics. Other causes for primary hypothyroidism are well known to you, like post-total thyroidectomy, iodine-induced destruction of the thyroid, and other reasons that were very clear to you. Now, the issue that comes to our mind is, since we're dealing with thyroid and hypothyroidism, what are the consequences on the mother and on the fetus? And then we are obviously in overt hypothyroidism. We know that there are consequences and well established. Catanism is well known, and the pictures that we have on our mind is quite clear on the clinical manifestation of overt hypothyroidism. Now, there are adverse effects seen on pregnancy outcome. I have to go a little bit fast. Pregnancy loss, placenta abruptia, in perinatal premature delivery with resulting low birth weight, preeclampsia, hypertensive disorders, non-reassuring fetal heart rate, increased rate of C-section, all those really mentioned. And finally, the most really worrisome is the adverse neurocognitive outcome in offspring measured in the form of IQ. Now, for subclinical hypothyroidism, it's a spectrum one would expect, since really it's obviously there are obvious adverse events in overt hypothyroidism. We should expect some adverse effects seen in subclinical hypothyroidism. But again, keep in mind that really the literature is based mostly on cohort studies, observational studies. There are a few randomized studies. So the data is heterogeneous and based on multiple reasons. One, as I mentioned, ethnicity, the level of TSH used for defining the state of hypothyroidism, and the methodology used in each lab. And so they do occur based on observational study, but most of them are based those on the level of TSH elevation and the presence or absence of thyroid antibodies. Those are the two elements that seem to affect mostly the pregnancy outcome that we've seen during pregnancy. Antibodies, the first study was done by Negro, and where he took a group with pregnant women who had positive antibodies and used control with negative antibodies. And his point is that the rate of miscarriage and premature delivery is very much affected by the presence of antibodies. So you have antibodies, you have increased risk for pregnancy outcome, increased pregnancy outcome. What if you have elevated TSH and antibodies? That's even a higher risk. In this Chinese study, they took around 3,000 Chinese women, and they divided them into 4 subgroups: euthyroid group, subclinical hypothyroidism, isolated thyroid autoimmunities, and the presence of subclinical hypo and thyroid antibodies. And the one subclinical, they divided them based on a TSH level. TSH group 1, TSH between 2.5 and 5.2, and the other one between 5.2 and less than 10. And for the other group, the same group having the addition of positive antibodies. And the result, again, that the highest odd ratio for pregnancy outcome was the one who had elevated TSH and positive antibodies. So the coexistence of both seems to be very influential as far as really pregnancy outcome. This, again, was confirmed in another retrospective cohort study. And actually there, they felt that the upper limit now, because just recently published and might have some influence on the upcoming guidelines, they took TSH 6 at the upper limit, not 4. But again, they realized that no association between thyroid antibodies and spontaneous abortion or premature delivery. Where there is true association is only when TSH is above 10. So it tells you how confusing the literature is. So you have to go what we have. What we have is TSH above 4, negative antibodies, you have to intervene. TSH is above 2.5 to 2 to 4, you may consider intervening. Above 4 with positive antibodies, you should intervene. Having said, what if those observational studies, what the effect of treatment? Do treatment with LT4 has any impact on really changing the frequency of pregnancy adverse event? And this is one study by Nazapur. He's from Azizi Group, well known to most of our endocrinologists from Tehran, where she tried to follow the same study done by Negro in 2006 and 2013 to reproduce it exactly to see the validity of the result of his study. And then she took a group with positive antibodies and those with elevated TSH. And here, her initial study was to look at the benefit of treatment with T4 in a group of subclinical hypothyroidism and negative antibodies, just to make it easy for you. And they used TSH 2.5 as the upper limit. And it seems that the presence of TSH with TSH at the upper limit of 2.5 has no effect on adverse outcome, but when they changed the upper limit of TSH to 4, it seems it became positive. So above 4, it seems there is a reduced risk of premature delivery, but not so much reduction of miscarriages. And what she looked at the effect of antibodies, and again, group treated with LT4, the other one not treated with T4. I have to go a little bit fast for sake of time. Again, she found no beneficial effect of LT4 in reducing preterm delivery in subclinical hypothyroid antibody positive women with the TSH cut of 2.5 to 4, but the upper limit was again 4, that was again positive. So she confirmed the results of Negro when it comes to premature delivery, but not really what comes to miscarriages. But again, it seems there is an impact. Having said this, I'll just go over this. Okay, what about cognitive dysfunction? And this is why I'll focus a few minutes there, because this is really the major impact. How much it has an impact. We know, like in overt hypothyroidism, it has an impact. What about in subclinical hypothyroidism? The key study was the one done by Lazarus, known as for you as CAT study. They look at antenatal thyroid screening and childhood cognitive function in subclinical hypothyroidism. For this, they randomize pregnant women at 15 weeks into two groups. Screening group, where they measure TSH and free T4 on the spot when they did the screening, and the control group, and they have their TSH, free T4 done immediately at delivery, not at the time of screening. And the screening group was considered positive if TSH was above the 95th percentile or the free T4 below the 2.5th percentile. And for those that really were tested positive, they give them 150 microgram per day and titrated for a TSH to keep it within the range of 0.1 to 1. And their primary outcome was IQ at 3 years of age, in children with mother with positive screening. And the result actually is that the IQ does not seem to be affected by whether you treat or not treat if you have subclinical hypothyroidism. So there's no effect on cognitive function. Now the other study is by Casey, and he uses TSH of 4 also at the more to define subclinical hypothyroidism. And he used a group where TSH was normal, but free T4 was low. As you know, this group has been described as potentially associated also with adverse effect. And again, his results were similar to the Lazarus study, that basically doesn't seem that intervening with LT4 has any impact on cognitive function. And further study actually was there was another large study that confirmed the same results. Having said this, over the last 3 minutes, how to act on this. So based on what I gave you, let me summarize what I gave you, so at least it will help you in deciding for yourself what is the best approach. So what we have shown you so far, that if your TSH above 4, there is room really to give patient medication, irrespective of the level of thyroid antibodies. Now, if your antibodies are positive, this is another reason where you should use LT4. Between 2.5 and 4, if thyroid antibodies are negative, most experts do not give any treatment. If thyroid antibodies are positive, some would use T4, some will not. So it's left at your own, basically, expertise to decide whether you should use T4 or not, having in mind that so far the study have shown the use of T4 during pregnancy has no major adverse effect on the outcome. Obviously below 4, negative antibodies, that the expert believe that really should not maybe observe the patient not doing anything else. Now, what if you have someone who has pre-existing hypothyroidism, what to do? Obviously, in this case, you know that there is increased requirement for thyroid medication, and that estimation is around 30% increase. So you can go by doing, estimate the amount of T4 that needed for the week and add that 30% increment and divide your dose over each day. Or you could say the easiest way is take 2 extra doses a week. So you give the treatment not for 7 days, for 9 days, over 7 days. So you add 2 extra doses from the first day that you know that the patient became pregnant. And you follow your patient by measuring TSH and 3T4. But again, keep in mind, once you increase the dose, you have to monitor your thyroid indices. And the opinion here is that you have to monitor your patient every 4 weeks for the first trimester, and at least once in the second trimester and once in the third trimester. And after delivery, remember to advise your patient that they have to reduce the dose of levothyroxine, usually to the pre-pregnancy dose, and then you follow your patient for further adjustment. Having said this, keep in mind, based on that coronavirus study, that over-treating is harmful, under-treatment is harmful. And this is based on a study in the Generation R study where they looked at the effect of over-treatment, under-treatment on the fetus as far as cognitive function, and they realized actually it's a reverse U-curve. Either over-treatment is bad, under-treatment is poor. And with this, I conclude it's what I showed you, that it's important to understand the physiological changes observed during pregnancy. I did mention that clinically it's no hint for you, but you have to rely on, if you have the possibility, on based population trimester-specific TSH concentration for TSH, and then that pregnancy complication are overall related based on the literature on the degree or biochemical severity of the hypothyroidism and the presence or absence of thyroid antibodies. And treatment is based on the physiological changes I did mention to you during pregnancy. Thank you very much.
Moving on to the last session of this reproductive medicine session, we have a very distinguished speaker. Dr. Ibtisam Baisa comes to us from the eastern province of Saudi Arabia, specifically Dammam. She's a consultant endocrinologist, head of department. She works in the Al-Rawda General Hospital, and she'll be telling us about the updates in polycystic ovarian syndrome. Dr. Ibtisam is a schoolmate with me. A few years ago, we graduated, and she'll tell you more about it.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Wa'am. It's my pleasure to be here today and share with you my talk. I'm talking about the update of polycystic ovary syndrome, and this is my disclosure of relation. And this is my objective. We'll discuss different aspects of polycystic ovaries, and then at the end, we'll have 2 quick case scenarios. Before I start, we have all to agree about some important facts about polycystic ovary. Before we proceed, we should all agree about this, so to make my life easier later. So as we know, polycystic ovary or Steen-Levithan syndrome, named after Steen-Levithan, who first described this syndrome, is the most common endocrine disorder that affects women during their reproductive years. It's most poorly understood and which is still incurable. So though the structure term polycystic is an integral part of the name, the presence of polycystic ovary is not an essential part of the condition. And in fact, polycystic ovary syndrome is a functional rather than structural disease. And the definition of polycystic ovary syndrome still controversial and subjective to different interpretations. So is it polycystic ovary syndrome or polycystic ovary disease? Although they are used interchangeably and also they may sound similar, however, there are slight differences between the two. So what is the difference between the polycystic ovary syndrome and disease? A disease is when there is a good understanding of the causative process, while a syndrome is something is considered when there is a set of specific correlated symptoms whose underlying direct cause is not fully understood, as they may be multiple and varied, as we have in polycystic syndrome. So polycystic ovary syndrome is a metabolic, hormonal, and psychosocial disorder with distinct biopsychosocial aspects and causing severe impact on women with polycystic ovary syndrome. Is usually a disease that is diagnosed when complications develop during the reproductive years that affect and impact the quality of life. So polycystic ovary disease is often starts at adolescence and teenage years. However, they are not diagnosed and misdiagnosed at this age, and the prevalence of polycystic ovaries is around 5 to 20%, and are almost 1 in 10% of women, they suffer from polycystic ovary syndrome, and unfortunately, less than 50% of those women are diagnosed appropriately, and also, unfortunately, that more than 50% of them, they will develop diabetes by the age of 40 or more. So a familial pattern occurs in some cases, suggesting a genetic component of the disorder, and results from studies have shown that shown some family clustering, and clustering that grounds a strong genetic basis in polycystic ovary syndrome, and also having a mother or a sister with polycystic ovary syndrome increases the risk of developing polycystic ovary syndrome up to 50%, and this is very important. And polycystic ovary syndrome phenotype does vary with ethnicity and geographical region as well. So this is a slide showing the summary of the genes involved in the pathophysiology of polycystic ovary syndrome. As you can see, there are many, and it is beyond our talk today to discuss them. Our colleague men, they should not sit back and relax, because we have a male equivalent of polycystic ovary syndrome. Men can develop clinical characteristics similar to the polycystic ovary syndrome, and studies have shown that brothers and sons of polycystic ovary syndrome subjects have high prevalence of metabolic syndrome, with their also most likely having the metabolic consequences like insulin resistance, obesity, type 2 diabetes, and early onset of alopecia, as well as prostatic hypertrophy and risk of cancer. And we have some syndromes also linked to this state. So let us now go to the diagnostic criteria. How do we diagnose polycystic ovary disease? This is the evolution of the diagnostic criteria. In early 1990, the National Institute of Health, they put 2 criteria and required both criteria to make the diagnosis. And this include menstrual irregularity due to olig or anovulation, plus clinical or biochemical hyperandrogenism. And in 2003, Rotterdam have put 3 criteria and required 2 of 3 those criteria to make the diagnosis. And this includes the menstrual irregularity, plus the clinical or biochemical hyperandrogenism, plus minus the polycystic ovary on ultrasound. In 2006, Androgen Access Society have set also 2 criteria and required both criteria for the diagnosis, and that includes hirsutism and or biochemical hyperandrogenemia, plus ovarian dysfunction, olig anovulation, and or polycystic ovary. Rotterdam criteria remains the most popular and widely used nowadays, and this was supported in 2018 by the International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovary Syndrome. So we have 4 phenotypes of polycystic ovary syndrome according to Rotterdam. The first 2, A and B, are the most common, where you have clinical and biochemical hyperandrogenism and ovulatory dysfunction. In type A, you have polycystic ovary, while not in type B. Type C lacks the ovulatory dysfunction while having the other, and type D lacks the clinical and biochemical hyperandrogenism while having ovulatory dysfunction and polycystic ovaries. So, criteria for the diagnosis of polycystic ovary disease in adolescent and menopausal women differ from those used for those women in the reproductive age. And we still lack the criteria for making the diagnosis at this particular age group, with varying diagnostic criteria still being debated, and we are waiting for more study to have more clear criteria to make the diagnosis at this age. So why it is difficult to diagnose those people at this age, the teen age and adolescent? Because 85% of the cycle are known to be anovulatory in the first year following menarche, and irregular menstruation is common up to 5 years after menarche, as well as clinical hyperandrogenism in terms of acne is common at this age. However, studies have shown that continued oligomenorrhea even after 2 years from the onset of menarche had increased risk of polycystic ovary syndrome in young adults. So this is a definition, the closest definition of irregular menstruation according to gynecologic age that we may help us to use. So if the girl is less than 1 year after menarche, then there is no clear criteria to make diagnosis of irregular menstrual cycle, and this irregularity is considered part of menarche. If they are between more than 1 year to less than 3 years after menarche, then any cycle less than 21 or more than 45 days is considered abnormal. If they are more than 3 years of menarche, then any cycle less than 21 or more than 35 or less than 8 cycles a year is considered abnormal. In menopause, again, this is difficult to make a diagnosis as ovulatory dysfunction is unreliable, and most of the guidelines suggest that the diagnosis at this age could be considered based on the previous history and previous diagnosis of polycystic ovary syndrome during the reproductive years. So let us now quickly move to the pathophysiology of polycystic ovary syndrome. And for the sake of time, it is just only summarized briefly in this slide. We start with some triggering factors that include environmental factors as well as the genetic predisposition and lifestyle that will result in the hormonal imbalance that takes place in the polycystic ovary disease, and this subsequently translated to the symptoms and signs that takes place in people with polycystic ovary disease, in addition to the psychological very important psychosocial aspect of that disease. This slide shows you the factor contributing to polycystic syndrome phenotype, and the aim of showing you this slide is to tell you or to show you the process, that the process of this disease is a continuous process, start from intrauterine life and continue to adulthood, to reproductive age, and continue even to the menopausal age with its subsequent cardiometabolic risk. So now let us move to the clinical features of polycystic ovary syndrome. Before we start, we have to note that considerable phenotypic variability occurs in the presentation. Some patients may have an individual component. Some patients may have more than one component. And lean individual also can have polycystic ovary disease. It's not a disease of obese people. And both lean and overweight may have also increased insulin resistance. And when insulin resistance is found in addition to other factors like hypertension, dyslipidemia, this may be called also syndrome X. Polycystic ovary syndrome is the most common cause of pathological infertility and hirsutism, and spectrum of presentation may vary, which may include also anovulatory women without hirsutism to hirsutism and regular menstruation. So it's really wide presentation. And hyperinsulinemia is likely to contribute to the disordered ovarian function and androgen excess and lead to the increase of those androgenic hormones. So obesity is very common. Up to 50% of people with polycystic ovary disease are obese, and more than 75 may be either obese or overweight. And the classic type of obesity here is what we call the android obesity or apple-shaped obesity. Hyperandrogenism with balding and balding pattern and excessive hair growth, and cystic acne is also one of the features, typically begin at the time of menarche. And however, one have to be careful when defining hirsutism, keeping in mind the ethnic background, because we know that people from the Middle East and from India, they are more hairy as compared to European people. We always, this is the commonest way to scale and score hirsutism, is called Furman and Galloway's scoring, where hair growth is scored in 11 androgen sensitive area, and each area is scored between 0 to 4 with a total score of 0 to 36. Anything is more than 8 is considered abnormal, between 8 to 15 is considered as mild, and anything above 15 is considered as moderate to severe. One have to remember also that women may have some few sexual hair in the upper lip or chin, and this is also very important to reassure the patient because many patients come with this problem. Similarly, alopecia is staged or scored, and this is one of the scoring called Ludwig grade system for women to score alopecia. And as with the hirsutism and the alopecia, acne also is scored from mild to severe cystic acne. So, and also this could correlate to the underlying pathology. So another problem is the menstrual dysfunction and ovulation, which is common. 2/3 of patients with polycystic ovary disease have anovulatory symptoms. Symptoms may vary from primary amenorrhea to oligomenorrhea or secondary amenorrhea to excessive frequent and irregular bleeding. So it's quite variable. And others may have regular cycle at first, then become irregular, and vice versa, may be irregular and become regular at later life. And normal menstrual cycle also does not necessarily signify ovulatory cycle. This is very important. And it is also in prospective study where they looked at normal volunteers. They found that 21% of those volunteers, they had cystic ovary while they don't have the disease. So the presence of ovarian cyst on ultrasound does not again confirm the diagnosis. And irregular menses are associated with increased metabolic risk and its consequences, and also chronic anovulation may increase the risk of endometrial cancer and hyperplasia. So this is a cycle of a normal woman where you have an ovulation at mid-cycle, and comparing it to a cycle of a woman with polycystic ovary disease, she has regular cycle but without ovulation. So this is what I was talking about. A regular cycle does not also signify ovulation, so this is very important. Acanthosis nigricans, again, another sign that may really target the diagnosis of insulin resistance, and in some severe cases of insulin resistance, patient may have acromegaloid feature or what we call pseudoacromegaly. Infertility is also one of the signs or symptoms of polycystic ovary disease. People with polycystic ovary disease, they can ovulate intermittently. Some of them, they may present with infertility, and some of them, they may present with increased miscarriage. Premature proparche or precocious puberty could be the earliest sign of polycystic ovary syndrome in the earlier age. So this slide shows you the prevalence of the clinical symptoms, and as you can see, menstrual irregularity is the most common, followed by the hirsutism and obesity, as well as hyperinsulinemia. So women with polycystic ovary syndrome, they are at increased risk of multiple factors. As you can see here, insulin type 2 diabetes and weight gain, hypertension, dyslipidemia, cardiovascular disease, stroke, autoimmune thyroiditis, depression, as well as breast cancer, cervical and endometrial, hyperplasia and cancer, and up to 35%, and in some other studies, up to 50% of them, they may develop diabetes by the age of 40 or more. Similarly, pregnant women with polycystic ovary syndrome, they are at increased risk of spontaneous abortion, impaired glucose tolerance, gestational diabetes in up to 50% of them, gestational hypertension or preeclampsia, and small for gestation age in up to 15% of those women. So in this slide, it summarizes the polycystic ovary syndrome hormonal changes that results in the cardiometabolic risk factor, the classic known cardiometabolic risk factor that we know, the dyslipidemia, hypertension, and so on, and in addition to other risk factors that still debated and under study that includes the vitamin D deficiency and gut microbiota. This all will result in premature atherosclerosis, early cardiovascular and stroke, as well as also one have to keep in mind the non-alcoholic fatty liver. They are at increased risk of a non-alcoholic fatty liver. So this is the natural history of polycystic ovary disease. The disease at young age, they present with reproductive symptoms, with menstrual irregularity, infertility, and so on. And as they grow older, they present with the metabolic component of this disease that includes the premature cardiovascular disease or renal disease, or cancer risk, as well as stroke and type 2 diabetes, and that affect the quality of life. This slide to remind you that the natural history does not start at reproductive age, but again, it starts in the intrauterine lifestyle to childhood and adolescent, where most patients at this age are not diagnosed. So what is a differential diagnosis of polycystic ovary syndrome? To make it easier, we have many differential diagnoses, but to make it easier to do, you can classify them to differential diagnoses associated with menstrual irregularity and hirsutism, or virilization and hirsutism, but have to note that there is overlap between those possible differential diagnoses. I will go over them quickly. The first differential diagnosis you have to rule out in this reproductive age is pregnancy and ectopic pregnancy, as they may present with amenorrhea and as well as abnormal uterine bleeding, and they are in reproductive life, and as I mentioned, they may ovulate intermittently as well. Hirsutism, again, is a common problem, and we have a big list of hirsutism. It's not only polycystic ovary disease. One have to take good history and differentiate the genetic factors, the physiological factors, and the idiopathic from the list of drugs that may result in hirsutism. You should be familiar with them. Hypothalamic amenorrhea especially occurs in athletes or people with anorexia nervosa with BMI less than 19. Usually they present with amenorrhea, and they may present with facial hair, but this is not hirsutism. You have to differentiate hirsutism from lanugo hair, which is fine hair, different than the hirsutism, which is thick terminal hair. Primary amenorrhea in menarche, they may present with amenorrhea, but the question here is you ask whether they have secondary sexual characteristic or not. If they have secondary sexual characteristic, then you should rule out anatomic abnormalities like imperforated hymen. If they don't have secondary sexual characteristic, then you have to think of genetic disorder, chromosomal abnormalities like Turner syndrome with its classic presentation of webbed neck, short fourth metatarsal, and so on. Cushing syndrome, whether it's primary, secondary, adrenal, central, or ectopic, they may have symptoms similar to polycystic ovary disease and sometimes may occur with polycystic ovaries. And we have features that, as I mentioned, overlapping between the two, like hirsutism and obesity. However, Cushing syndrome is characterized by thin skin, purple striae, and proximal myopathy. Hyperprolactinemia, again, mild hyperprolactinemia may take place in polycystic ovary syndrome, and you should rule out other causes of hyperprolactinemia that you all know about, and we have discussed this earlier. Pituitary prolactinoma should be suspected if you have serum prolactin more than 200, and if the patient has macroprolactinoma, then you should check for the increased intracranial symptoms as well as bitumoral hemianopia. Ovarian and adrenal tumor, again, this is another differential diagnosis, should always be serious to rule them. However, they present with severe symptoms of hirsutism and virilization like in ovarian and adrenal tumors. Sorry, I'm a bit fast for the sake of time. Congenital adrenal hyperplasia, again, they may present again at a younger age, and the most common of which is 21-hydroxylase deficiency, and they are usually diagnosed by the elevated 17-hydroxyprogesterone. Anabolic steroid abuse for bodybuilding, they may act like testosterone and may present with, again, similar features. You should always consider it in history. The association of polycystic ovary syndrome and autoimmune thyroid disease is increasingly being recognized, and increased in ovulation, ovarian volume also, and cystic changes have been also observed in people with primary hypothyroidism. So how would you approach the patient? The most important is you take detailed history like any other disease to differentiate those things, and then you confirm it with the physical examination and investigation. These are the important aspects of the clinical history. We don't have time to go over them in detail, but in general, you should always look at the age of onset, the severity of the symptom, whether it's hirsutism, virilization, the weight of patients, if the presence of hypertension or metabolic factors, menstrual irregularity and its severity, and the presence of medication. And these are the important aspects in the physical examination, include checking the weight, the blood pressure, scoring the hirsutism, examining the thyroid, examining for galactorrhea, signs of Cushing syndrome, as well as acanthosis nigricans, insulin resistance sign, and also examining the abdomen for any ovarian tumors or masses, and as well as any signs of virilization to suggest virilizing tumors. So let us now go quickly over the investigations. Up to 70% of patients with polycystic ovary have increased level of adrenal androgen, and this is the required baseline or initial androgen to be requested is LH and FSH. Normal ratio is less than 2%. Testosterone, free testosterone, up to 70 nanogram is considered normal, or 2.4 nanomole. Dihydroepiandrosterone sulfate, normal is up to 380 microgram or 10.2 micromole. In addition to checking for serum glucose and fasting lipid profile and prolactin. Women with polycystic ovary disease, usually they have an increased ratio of LH-FSH of more than 2.5. They may have mild elevation of testosterone, dihydroepiandrosterone sulfate, as well as serum prolactin, and they may have an increased ratio of insulin, glucose to insulin, that may indicate insulin resistance. And moderate degree of cyclic, diurnal, and episodic variation should always be considered when testing the hormones. So also you should always consider the testing and evaluating the cardiometabolic risk, checking blood pressure, dyslipidemia, looking for fatty liver with liver enzymes, and should do that annually if you confirm that the patient has polycystic ovary syndrome. So additional investigation include transabdominal ultrasound or transvaginal ultrasound is more sensitive. But again, we have to remember that a normal ultrasound does not rule out the diagnosis, and the presence of cystic ovaries does not confirm the diagnosis of polycystic ovary syndrome alone. As we said, 23% of normal may have cystic ovaries. So this is the expert consensus recommendation in regard to the ultrasound recommendation, diagnosis of polycystic ovary. They all agreed that the volume of the ovary should be more than 10 centimeter. However, early on, they agreed that we should have at least 12 or more follicle of 2 to 9 millimeter, but with the development of the ultrasound, they increased this number to 25 or more follicle, less than 10 millimeter. So, and also they recommended that ultrasound is not a good option for people less than 8 years of menarche, and transvaginal is more sensitive. Further investigation to rule out other differential diagnoses that we have mentioned, and clues to the diagnosis. Idiopathic hirsutism, usually they don't present with other abnormalities or menstrual irregularities. Polycystic ovary, they have mild elevation of testosterone, prolactin, increased ratio of LH, FSH. People with ovarian and adrenal tumor, usually the testosterone is very high, more than 500. Adrenal tumor, dihydroepiandrosterone sulfate is more than 700. And congenital adrenal hyperplasia is diagnosed by high 17-hydroxyprogesterone of more than 200 that is stimulated by ACTH test to more than 1,000. And medication is self-explanatory. So I'll just quickly, I know that I don't have time, but I'll just go quickly over the possible medication that we use to treat polycystic ovary syndrome. But we have to note that we have limited data on the proper treatment, as many of the manifestation of the condition may be a component of other disease. So our goal of the treatment is to reduce hair growth and acne, manipulating the cycle, and reestablish fertility, and also treat and target the cardiometabolic risks and psychological support. And we know that the treatment of polycystic ovary syndrome is multifactorial. We need a dietitian for weight control, physician and endocrinologist for the metabolic disorder, gynecologist, and the fertility for induction of ovulation, and we need the support team. So, treatment of hirsutism, we start with non-pharmacological agents, the usual way of laser or electrolysis or shaving, and the pharmacological therapy, but we have to remind the patient not to expect good results until 3 to 6 months, and the response should be evaluated by the hirsutism score. And the first drug to use here is the oral contraceptive, Diane. It suppresses the ovarian androgen, and clinically the effect is tested clinically by the clinical presentation and the testosterone. Adverse reaction, as you all know, weight gain and thromboembolization. Other modality of treatment is aldactone or spironolactone. Again, reduces testosterone production and block androgen receptors, and it can be used in up to 100 milligram once daily or twice daily on a daily basis or on a cyclical pattern to reduce the risk of menstrual irregularity. You have always to monitor the serum potassium, and you should preferably add oral contraceptive for better results and also to prevent pregnancy. Cyproterone acetate, another also modality of treatment to block androgen synthesis is effective alone or with oral contraceptive pill, and it may be given for 10 days from day 5 to day 15 of the cycle. You should monitor always the liver enzyme. The finasteride or Broscar, this is the drug used to treat prostatic hypertrophy, and it can be used off-label to treat polycystic ovary disease, especially if they have alopecia, and it have shown to improve the alopecia. However, one have to be careful about pregnancy, and pregnancy should be ruled out before starting this treatment. For the treatment of menstrual irregularities, we have the oral contraceptive is the first line of treatment for the treatment of menstrual irregularities. And again, absence of pregnancy is important to be confirmed before starting the treatment. This is the strategies to reduce obesity and weight, and 50%, and it have been shown that 5% reduction of weight will result in improvement in the condition and the symptoms as well as insulin resistance. Metformin is the top of the list, and it enhances peripheral action, and we have still controversial issues whether to use it in people without diabetes and in non-obese and in also menarche or adolescent care. And studies have shown that metformin alone may improve the insulin resistance, and especially if it is used with clomiphene and induce ovulation as well as pregnancy, and reduces even the risk of abortion and early pregnancy loss, especially with previous loss. And we have the bioglitazone, again, it's one drug to use for improved insulin sensitivity. And for induction of ovulation, we have the clomiphene citrate. I will just skip them quickly because of the time. We have the clomiphene citrate, and we have also the letrozole is used to induce ovulation for those with infertility. And usually the patient responds within 6 cycles. If they don't respond, then we have the pulsatile GnRH treatment therapy. However, the risk of multiple pregnancies and hyperstimulation syndrome, which is a life-threatening condition, is there. Other treatment, in vitro fertilization, again, if they fail to achieve fertility with the other modalities, and surgical treatment. And we have the transabdominal surgery is replaced by the laparoscopic surgery in view of the complications. And we have the ovarian drilling and the laparoscopic ovarian surgery that may be used to treat those people. Psychological support is important because it has been shown that those people, they are at high risk of depression and substance abuse and smoking. So this summarizes the management. The first question you need to ask whether they want ovulation induction and fertility. If no, then the first treatment of choice will be with oral contraceptive pills plus addressing the other issues like obesity and insulin resistance, hirsutism, and acne. And for the, if they seek ovulation and fertility, then with the treatment to stimulate the ovulation. Under debate and still processing is the vitamin D. Some studies have shown that vitamin D deficiency may play a role in insulin resistance, and some studies have shown that giving vitamin D may enhance menstrual cycle and ovulation and blood glucose as well. And similarly, the gut microbiota, again, it is linked with insulin resistance and polycystic ovary disease, and have shown that they may promote and reduce ovarian inflammation. And we all know the GLP-1 receptor agonist to treat obesity and insulin resistance, similarly the bariatric surgery and its role in obesity. So I'll just end in 2 minutes, the 2 quick case scenarios. This is a 25-year-old woman with oligomenorrhea. She's overweight, BMI 29. She has minimal acne on face with dark hair on her upper lip and upper and lower abdomen and inner thighs with a score of 10. She has mild hirsutism. She has mild acanthosis nigricans. LH-FSH ratio is more than 2.5. She has mild elevation of testosterone, dihydroepiandrosterone sulfate, and the rest of investigation is normal, including ultrasound. So this is a case of polycystic ovary syndrome based on the Rotterdam criteria, as she has menstrual irregularity, she has clinical hyperandrogenism with hirsutism and acanthosis nigricans, and with biochemical as well, with high LH-FSH, mild elevation of testosterone, prolactin, and dihydroepiandrosterone, and a normal ultrasound does not rule out the diagnosis. And the treatment here is with oral contraceptive plus minus metformin if she does not seek pregnancy. If she seeks fertility, then clomiphene with metformin. This is a second case, 51-year-old lady, perimenopausal, with past medical history of polycystic ovary disease, was referred with 2 years history of progressive hirsutism and deepening of voice. Her initial hirsutism score was 12. Now she presents with a score of 27, which is severe. Accompanied by baldness and deepening of voice, and she has male pattern, grade 3 of her baldness, and this is her investigation. Her testosterone is more than 500, so it's severely elevated. Her dihydroepiandrosterone sulfate is mildly elevated, and the rest of investigation were normal, except for the previous ultrasound that showed 12 by 15 millimeter left ovarian cyst, which was not there in the recent ultrasound, and a recent MRI confirmed the presence of 17 millimeter left ovarian mass, So what is the diagnosis here? This is a hyperandrogenemia around menopause, which is a rare condition. Initially, it was, in this case, because of polycystic ovary disease, and now because of the ovarian secreting tumor, most likely because her testosterone is very high, unlikely adrenal because her dihydroepiandrosterone sulfate is less than 700. So there was a question whether there is link between the two. Some studies have supported that there is a link between polycystic ovary and tumors. The treatment in this case is surgery. And with that, I would just conclude here. I will just skip this because of the time. Just only a normal ultrasound, I would re-emphasize on this, that does not exclude the diagnosis, and the presence of ovarian cyst does not confirm the diagnosis. We are left with still many debates and controversies, including also using the anti-Mullerian hormone for making the diagnosis around adolescent, menopause, and so on. So these are the misconceptions, and polycystic ovary disease is currently untreatable condition, incurable, and continuous process. With that, I would like to thank you.
Speakers and my co-chair. We have a few minutes for questions.
Great talks, three great, excellent talks. I have a question to Dr. Muhammad regarding, as we know, we're using a lot we're using GLP-1 inhibitors quite frequently for obesity, for type 2 diabetes, and we stop them when patients get pregnant. And obviously, a lot of them will need insulin. My question is regarding that weight gain that will happen. Does it change our approach? And then are there any outcome studies for looking at this?
Thank you very much for asking this question, because it's an excellent question. So ideally, if we know the women are going to get pregnant, we should not be using these agents. However, most of the women will not plan it. So what we have observed is exactly what you just mentioned. So the minute the GLP-1 agonists are stopped, there is a rise in the weight and a rise in the and worsening of the glycemia. And we left, especially if we got them early, we try as much as possible to get things under control. But if you get them late, you will find that glycemic control has worsened rapidly, and they gain a lot of weight very quickly. So this rebound here is very, very difficult even to predict. So we're more conscious of it, and we treat aggressively once we know that the woman was in GLP-1. Absolutely.
Thanks a lot for this really nice presentation. My question for Dr. Sam. For this patient with polycystic ovary, which is you cannot find cyst or virilizing tumor, as the two cases, do you come across ovarian hypertrichosis, like it's overlapping with PCOS?
Yes, it's applied
as
to this.
only we can diagnose surgically, like postmenopausal woman, common, and with excessive hirsutism, like the same scenario of the second case.
So I'm not sure whether I understood your question.
No, I speak about ovarian hypertrichosis.
Hypertrichosis, yes.
This is almost like the second scenario case,
exactly.
But we cannot find virilizing tumor.
Cannot
And the
find
diagnosis only surgically.
By surgical, this is what
We
I
cannot
mean.
find
Yes.
cyst or
Exactly,
mass.
this is what I mean. Ultrasound is not sensitive to make the diagnosis of these cases, yes.
Just like the other, I would like to thank the three of you. It's an excellent presentation. The problem, you left the questions to the last minute, and we forget, Age has something to do with it. I think, to the first speaker, Dr. Muhammad, I was in England for sometimes, and we used to run something called pre-conceptual conception clinic, where we prepared, the woman prepared herself, for pregnancy by losing weight, by monitoring the blood pressure, by monitoring everything. So in a way, so when she wants to be pregnant, that would be and control of diabetes. I think it looks to be strange, to treat everything. Of course, you could not control pregnancy. Could be pregnant, come to you pregnant at any time. So when she, if you prepare her, by controlling the blood pressure, by controlling her diabetes, that certainly will be better outcome. Okay, I have other points, but I will leave them. For the thyroid, I think the most important to me is the antibodies. To me, I think that certainly would tell you the present most common cause of hypothyroid is Hashimoto. in case, especially women. And once you have Hashimoto, you would look for other diseases which could be associated with it, as polyglandular syndrome, something like this, But and the other thing, I think the TSH, I agree with you, that should be lower, possibly 1 or 2, okay? And with this pregnancy will be possibly not lower than 1, no doubt, And I think now, possibly, if you measure T3 is very important, You see, the problem with it is that TSH is the, previously we said, considering this is the standard, what you say. But you see, there's a syndrome which has been discovered recently where you have deamination problem hereditary, where you don't, from T4 to T3. Okay? Because sometimes you have to give T3 if this patient is positive for it, And there's many other questions for it, The other third speaker, I would just say that certainly I believe that all of the syndrome of polycystic ovary is due to insulin resistance. Okay, And I think the insulin sometimes facilitator and sometimes blocker. Okay, so in a way, when it reaches the ovary, and possibly the testis, it is facilitator. Okay, so it will produce the androgens. That case, and the androgen supposedly to change to estrogen. Okay, so I think.
Dr. Ghazi, thank you. We need to give time to others.
I'm sorry. It's just the 3 questions because you delayed it.
I take your point. Thank you very much for the type of question you ask. I think more than T3 is now that you might find is the low free T4, which there has been some talk about it, that you do TSH free T4 and TSH is normal, but free T4 is on the low side. And this is what they call isolated hypothyroxanemia, and has been linked based on observational study on some attention deficit disorder and some premature delivery. But the data is not very consistent, and the effect of thyroid medication has not shown to be quite effective in preventing the pregnancy adverse effect. But the one thing in those cases is that if it's persistent, you have to think there's a problem in the conversion of free T4 to T3. That's why your free T4 is high. And that's what we see in iodine deficiency area. The iodine deficiency, when you see this type of low free T4, always think that might be some iodine deficiency and make certain that the patient iodine supplement is really being taken care of. Because when you correct the iodine deficiency, that free T4 is corrected. But the issue is measurement in pregnancy is not very reliable for the free T3, even in non-pregnant cases.
Thanks to all speakers, great presentation. And my question to Dr. Mohammed Bashir about the treatment of diabetes in pregnancy. I heard about the use of metformin and also the use of metformin type 2. Now, if you have the choice and your patient coming to you is in early pregnancy, type 2, and was on metformin, would you switch from the beginning, or you wait to see how she is doing with her first response during her first trimester?
So I switch her from metformin
to insulin.
No, we keep the metformin.
Type 2.
Type 2, yeah.
You keep her on metformin?
We keep the metformin. We stop everything else, but we keep the metformin. We don't stop it.
And then you continue watching her not reaching the goals?
No, we keep with the goals. We keep the metformin going. We add the insulin on board.
On board, then you keep the metformin.
So as I said, one of the so metformin has been tested in pregnancy in controlling the weight gain. That's one part.
Right.
And it has been tested in pregnancy in obese patients. So before the meta-trial came approach, we were leaving the metformin on board because we found it very useful in reducing the insulin doses and actually in controlling the gestational weight gain. I had no time to go through type 1 diabetes, but I can tell you in some patients with type 1 diabetes even, metformin can actually have a role in them because they become extremely insulin resistant, and that's the only way to break this that we have. The only tool we have is metformin.
What about the controversial issue of the effect on the baby, after delivery long term, about the metabolic, issues? I'd like you to comment on this.
Thanks for bringing this up, because the evidence here is, again, not 100% clear. So you take the studies that came from Australia, and they found inconsistent results depending on where they looked at. So different population with different results. And then you find other studies that looked at the babies, and they found they did not replicate what the Australian found. So the issue is related to body weight by certain age, and that patient, baby treated with metformin might be disadvantaged intrauterine, and then they gain a lot of weight later on in order to compensate or catch up. So that has not been consistently found. And most recently, the MITI trial has published their own follow-up studies, and they found no difference in the body weight between the children. So the initial study that came out and went a little bit too far in their predictions based on their subgroup analysis.
So no more controversy?
No, the controversies are still there. We don't have an answer, definitely 100%. The controversies are still there, but it all have to do between the benefits, risk-benefit ratios, and that's where you need to go.
Thank you very much.
Thank you.
Thank you all for the informative presentations. My question is to Dr. Mohammed regarding the study that you have done, aiming the kilocalories to be 1,600. Is there any diet which is superior to other diets that has been done in your studies that would you recommend for GDM?
Okay, thank you very much. So it's a change in practice rather than anything else for us. We went with the 1,600 calories with a certain group of patients, and we looked at before and after our intervention. So, but the very important concept about diet in pregnancy that it is not diet in terms of trying to get them to lose weight. It's the concept about pregnancy is that there are a minimum amount of carbs that they need in order to have a healthy pregnancy, and this amount of carbs has to be split into 6 different meals in order to avoid any surge in glucose. So in our cohort, when we start to implement the 1,600 calories, in those with excessive gestational weight gain, we managed to stop it in 2/3 of the patients. We haven't published that. And in those patients where we think at high risk of having excessive gestational weight gain, we prevented it in over 70% of the patient. And the important safety part here is while you're doing that, you need to monitor the ketones of the women when they come to the clinic. Because if they start to become ketotic, that's not too much reduction, and ketones are very harmful, so you have to abolish that immediately. But we had no problem with ketonuria all the way through so far. The Danish study used lower calories than we did, 14,000 calories, found no evidence of ketonuria. So this is an important part while you're managing it.
I don't think you have too many happy pregnant women going with you. I mean, this is the time where you look really to indulge on their eating habits, and I think really limiting their intake becomes really very difficult.
We can comment on that in a different way. 1,600 calories is not a small amount of calories. And so the traditional one is 2,000 calories, 1,800 calories, and 1,600 calories. And if I picked any lady here and I told her if I gave you 1,800 calories of food, she's more than what she's actually currently taking, she's going to gain weight on them. So 1,600 calories seems low, however, it's actually not. And it's divided on different meals in such a way that the women don't get full, don't get hungry. And we try to make it as enjoyable as possible.
Okay, I think we come to the end of the session. It was a fantastic session and very educational. I thank all my 3 distinguished, excellent speakers. Thank my co-chair, Dr. Ali, and thank you all for being here.